I am Andrea Green-Heinz, Assistant Professor of Adult and Pediatric Infectious Diseases at the University of Nebraska Medical Center and Children's Hospital and Medical Center. I also serve as the Medical Director for the Children's Hospital and Medical Center's Antimicrobial Stewardship Program. I was invited by ASAP to talk about outpatient antimicrobial stewardship and patient communication strategies, given my experience talking with patients and families about when antibiotics are needed and not needed. 30% of the 269 million antibiotic prescriptions dispensed in our communities annually are unnecessary. We also know that every year there are more than 140,000 ER visits for reactions to antibiotics, and in the U.S., antibiotic resistance causes 23,000 deaths and more than 2 million illnesses annually. There are many potential barriers in outpatient antimicrobial stewardship. Clinicians commonly perceive that the desire for antibiotics is a key driver of office visits. Clinicians also have concerns about decreased patient satisfaction and therefore are concerned with losing patients to other clinicians if antibiotics are not prescribed. We know from prior research that any parent-initiated statement of antibiotics during an office visit increases the likelihood that the physician perceives the parent as expecting antibiotics. This statement can come in the form of a direct or indirect request. An example of a direct request is, "I would like for you to prescribe antibiotics." An example of an indirect request, which parents are more likely to use than a direct request, is, "Our neighbor boy has similar symptoms and received antibiotics from his physician." Perceived patient and parental pressure has been shown to result in increased overprescribing of antibiotics. We also know that physicians are not good at predicting what parents or patients actually expect, and we often overestimate the actual pressure to prescribe antibiotics. It is therefore imperative that we improve our communication practices during these office visits in order to optimize outpatient antimicrobial stewardship. It is also important to further understand what these indirect parent communication practices may look and sound like in order to actively manage expectations for antibiotics during the visit. The next two slides contain information about communication training developed as part of a dialogue around respiratory illness treatment, or DART, a quality improvement program by project team members at Seattle Children's Research Institute and the University of Washington Active Medical Training Resources Program. Let's look further at what indirect communication from patients or their parents may look like. An indirect communication practice from patients or their parents may come in the form of a candidate diagnosis. When parents offer a candidate diagnosis, they are 25% more likely to expect antibiotics for their child. A candidate diagnosis may be explicit, where a patient or parent names a potential diagnosis, for example, sinusitis. A candidate diagnosis may be implicit, where the parent or patient gives a description of symptoms that implies a particular diagnosis. For example, they may mention a contact with similar symptoms that has a particular diagnosis. There are 4 key communication practices you can use to successfully manage patient or parent expectations for antibiotics. Number 1, review your physical exam findings. 2, deliver a clear diagnosis. 3, use a 2-part negative positive treatment recommendation. And 4, provide a contingency plan. Let's look further at the 2-part treatment recommendation. A cross-sectional study conducted on over 1,000 pediatric acute respiratory tract infection visits showed that positive treatment recommendations, which are explanations of what parents can do to help their children's symptoms, for example, you can give ibuprofen to make her comfortable, with or without negative treatment recommendations, which are explanations of the inappropriateness of antibiotics for their child's infection. For example, this is caused by a virus, so antibiotics won't help, are associated with decreased antibiotic prescribing. In addition, the study showed that combined positive and negative treatment recommendations are associated with the highest possible visit rating. Let's review the key communication practices further. It may be helpful to think of them as the 4 E's. First E, examine. Review physical exam findings and deliver a clear diagnosis. For example, your ears look good and your lungs sound clear, which is good. Your throat is a bit red, but nothing that warrants concern. It looks like you have a nasty cold. Second E, empathize. Validate the patient's symptoms and illness while providing reassurance. For example, these colds can make you feel pretty awful, but thankfully they aren't dangerous. The third E, explain the treatment. Start with negative treatment recommendations. For example, your sore throat is caused by a virus, so antibiotics won't help. Then provide positive treatment recommendations. For example, there are lots of things you can do to help with your symptoms. Taking ibuprofen and drinking plenty of fluids will help you feel better. Create a contingency plan. For example, your cough may last from several more days to several weeks, and it may take a while for you to feel better. I want you to call me if you're still coughing after 3 weeks, or if you begin coughing blood. The fourth E, educate. If patients do push for antibiotics, discuss facts about viral infections and antibiotics, including adverse effects. For example, our goal is to help your immune system fight the virus. Taking antibiotics can be harmful by destroying the good bacteria that protect your body. When you use antibiotics when you don't need them, the next time you do need an antibiotic, the infection may be more resistant to antibiotic therapy. Thank you for listening to this module on outpatient antimicrobial stewardship and patient communication strategies. Remember that outpatient antimicrobial stewardship is important in combating antimicrobial resistance and unnecessary adverse side effects from antibiotic therapy, and that you are capable of delivering optimal care through antimicrobial stewardship while still maintaining patient satisfaction.